So, start off with, let's have an ECG of the week. So this is a really good ECG. This is the kind of ECG that when you see it in the flesh, your heart will start to do something quite similar to this, because you'll think, oh my goodness, what on earth is going on? So this patient is a 30-year-old girl, and she is feeling pretty lightheaded and breathless, but she's conscious and aware of her heart racing. So what do you think this ECG shows? Nothing on the chat. So it's quite a difficult ECG. When you've seen this ECG, you will know what it is next time round. So I've had a suggestion on polymorphic VT. So it's a great suggestion because it's clearly not monomorphic VT, but I'd put it to you that some of the complexes in it are pretty consistent. So while I agree it's not monomorphic VT, if it were polymorphic, there would be no regularity to the complexes. And most of these ones along the bottom, can you see along this section here, are all basically the same. So I've had a suggestion that it's an SVT. So if this is a supraventricular tachycardia, we would normally expect a typical right or left bundle branch block to go along with it. So I'm not saying it is or isn't a supraventricular tachycardia, but it's not typical of that. So is it regular or is it irregular? So I've had both options. So if you look on the bottom, can you see how there's some RR intervals which are quite wide and there are others that are pretty short? And if you look along, no two RR intervals are really the same on consecutive beats. So this is irregular. So does that help you towards a diagnosis? So the other thing to spot as you go along is that most of the QRS complexes are the same, but there are others along here that aren't the same. And that's why we had the suggestion that this might be polymorphic VT. And can you see that there's one here that's quite different at the start? And there's another one over here that's different. And there's another one here, which is different again. So we have variable appearances intermittently, but for the most part, it all looks the same. Dr. Al has suggested fast AF. So when you say fast AF, why do you think this is fast AF, given that it doesn't look like a typical left bundle branch block pattern? So you can't see P waves, but if this was a VT, you wouldn't necessarily be able to see P waves. So it's not the presence or absence of P waves when it's as tachycardic as this. But the fact that it's irregular can point you in the direction of atrial fibrillation, because VT should normally be regular. Polymorphic VT is different, but this isn't polymorphic VT, as we said, because most of the complexes are the same. So can you look at the appearances in V5, V6 and look how long it takes for the upstroke of the R wave? So it's a very slow progression of the R wave. Does that help you at all? So there is a delta wave here. So this is Wolff-Parkinson-White, and the atrial fibrillation is conducting through the accessory pathway. And what do we call this? So we call this pre-excited AF. So AVNRT is atrioventricular nodal reentry tachycardia, and that's a different condition from Wolff-Parkinson-White. I'd have to go into that another time, I think. But no, this is pre-excited atrial fibrillation. And what you're looking for is an irregular rhythm, uh, potentially a fast rate. The rate depends upon how fast the accessory pathway will conduct, which in some cases is very fast indeed, in other cases is not that fast. If it won't conduct that fast, then you don't have too much of a problem, because it controls the rate for you. But if you've got a very slick, eager to conduct accessory pathway, then the ventricle gets exposed to the very fast rates of atrial fibrillation. Atrial fibrillation, the atria is probably the swirling, chaotic electroactivity swirls about 300 to 500 times a minute. And if you expose the ventricle to that sort of rate, you put it into VF very rapidly. And sometimes along the way, you get fusion beats or potentially capture beats where you get some of the conduction through the AV node and some of it through the accessory pathway. So this is pre-excited AF, and it's something to watch out for. And what do you do to treat this? What would you do to treat this patient? Bearing in mind that she's just about hemodynamically stable, but she's not very happy. So do you want to give her some beta blockers to slow down the atrial fibrillation, or do you want to give some verapamil? Because beta blockers are not good in pre-excited AF, but verapamil manages to slow down the atrial rate, the atrial fibrillation rate, without causing any harm. Or would you like to give some flecainide? Flecainide avoids the issues that you have with beta blockers and verapamil, and will slow the rate of conduction. Or do you want to give some electricity? Do you want to shock this patient back into sinus rhythm? So A, beta blockers, B, verapamil or diltiazem, C, flecainide, or D, electricity. Oh, so lots of uncertainty about what you do when faced with pre-excited AF. So Ben is saying C, excellent. Yes, flecainide is the drug of choice because flecainide will slow conduction through the accessory pathway and through the AV node. So if you give flecainide, that could potentially cardiovert, it could slow her down. If you give beta blockers or verapamil, they'll slow conduction through the AV node, but they won't necessarily affect conduction through the accessory pathway, and those can actually speed up the pre-excited AF and put her into ventricular fibrillation. If that happens, then you'll be able to shock her back into sinus rhythm and she'll be fine, but you probably don't want that level of excitement in your A&E, do you? Other options, you could try digoxin. No, because that'll do the same thing as beta blockers on calcium channel blockers. Or amiodarone, well, that has some cardioverting effects and different effects, but it also has beta blocker properties, so you'd best avoid that as well. So options here are either flecainide or electricity. Wonderful. So let's move on to the heart failure bit of the talk. So can anybody tell me, why do we get heart failure? So heart failure is a syndrome in which, in fact, it's more a constellation of symptoms that you get when the cardiac output is insufficient to meet the metabolic demands of the body. And we talked about the different types of heart failure. Heart failure with left ventricular systolic impairment, heart failure with a preserved ejection fraction, valvular heart failure, right heart failure, high output cardiac failure. We talked about those last time, so I'm not going to go over those again. But why do we get heart failure? I mean, the person in front of us, their heart's beating. It's not going to stop by the end of our consultation. The heart doesn't work at um, in an energy debt situation, so it doesn't have anaerobic metabolism going on. So why does it gradually fail? So what actually causes us to get heart failure? What causes all the symptoms, the negative impact of it? So the answer to that is that it's the unhelpful way that the body responds to development of weakness of the heart, or I shouldn't say weakness because there are lots of different forms, insufficiency of the heart. So there are two different ways of thinking of it. Why does the body respond badly? Well, it's because your body isn't geared up to saying, I've got a weak heart, I need to look after it. Your body instead is very good at saying, ouch, I've been mauled by a saber-toothed tiger. I desperately need to make my heart work harder in order that, although it's not pumping very well, it pumps as much as it possibly can and meets my body's needs. So imagine you lose a lot of blood. The heart body detects that in the same way it detects heart failure and responds to it in basically the same way to make you pump out adrenaline and to make you retain salt and water. Another slightly less spectacular way of thinking about it is to imagine that you're very dehydrated. So the body recognizes that your cardiac output is low, but it assumes it's because you're dehydrated and it needs to cling on to as much salt and water as possible in order to restore circulating blood volumes, and that it thinks is going to deal with the situation. It doesn't say, I've got a weak heart, I need to look after it. And if only your body was really good at looking after your weak heart, we wouldn't have to die of heart failure. But of course, when we were evolving, it didn't matter if you died when you were 40 or 50 or 60 of heart failure. If you had a myocardial infarction, that was basically curtains, so you didn't have to deal with the aftermath of it. So we have processes in the kidneys, the RAS system, and we also have processes in the brain which work with the baroreceptors. I'll just tell you very briefly a little bit more about that in a second. And these processes cause fluid retention. And these processes over here, the baroreceptor response, that causes sympathetic drive and heart rate increase, contractility increase. And all of these in the short term can be helpful. And somebody who's very acutely unwell with heart failure, it can be helpful to have that adrenaline driving things and the increase in heart rate, maintaining what little blood pressure that they might have. But in the long term, these are very negative impacts because you have an increased workload of the heart, and you have myocyte growth, and this leads to hypertrophy. I very briefly, the kidney side of things, the renal angiotensin aldosterone system. The kidneys produce renin when you have got a decrease in perfusion, and the renin converts angiotensinogen to angiotensin 1. Our ACE inhibitors work here and block the conversion to angiotensin 2, so that's why ACE inhibitors are so effective. Angiotensin 2 goes into lots and lots of other things, but the important thing here is that these are the angiotensin receptors, and this is where our angiotensin receptor blockers work. There's the other route in with the aldosterone, and the spironolactone is a mineralocorticoid and receptor antagonist, and that works here. So there are lots of different drugs that we have to block these systems, the big categories being the spironolactone type drugs, ACE inhibitors, and the angiotensin receptor blocker drugs. And then the sympathetic system that we just talked about, we've got baroreceptors that discover that your blood pressure is lower than it should be on the aortic arch and the carotid sinuses, and there are some elsewhere as well. And these go to the brain, and then they go through the sympathetic nervous system to do things like increase the heart rate and to vasoconstrict blood vessels to push up blood pressure and increase the cardiac output and to maintain supply to critical organs. And these processes are all, as I said, in the very acute phase, they can be helpful, but in the long run, they are very, very harmful. And heart failure, I think it's quite useful to think of Star Wars. I'm a big fan of Star Wars. I grew up with Star Wars, and then there's been another wave of Star Wars. And I tend to think of all that I've been describing as being the dark side of heart failure, the negative way that the body responds to it. But there is also a light side of heart failure, and that is the natriuretic peptide system. So natriuretic peptides do exactly what they say on the tin. They make you pee sodium, natria, sodium, uretic pee. They make you pee out sodium. And sacubitril is the drug that we have available to us. There've been others, but this is the first one that doesn't cause serious side effects. And so sacubitril paired up with valsartan, it's a combined salt complex, so you have to give both together in the drug as things stand. So giving sacubitril augments the natural helpful process, which in health doesn't kick in until far too late. So by augmenting that, you get more function of the natriuretic peptide system earlier in the heart failure cycle. And these counter many of the harmful effects. So they make you, rather than retaining salt and water, you get rid of salt and water, and you obviously get rid of fluid with that, and you vasodilate the blood vessels. So these can be extremely helpful by pointing at the wrong side of the slide. This is increased secretion, gets you to pee out, and it inhibits the RAS activity. So really useful new treatments. Sacubitril valsartan is about 20% more effective than an ACE inhibitor. So it's a good new drug for left ventricular systolic impairment. As I said last week, it all comes down to ejection fraction. If your heart is weak because there's systolic impairment, and that means it's not pumping well because it's not actually pumping, that benefits from all sorts of really important, useful medications. If, on the other hand, your heart is a preserved ejection fraction heart failure, think of that as stiffness, because that's the easy way of thinking it. But unfortunately, these drugs are not helpful with a preserved ejection fraction. So, very important to make sure that you treat heart failure patients well if I'm your consultant of the week, because otherwise you could end up reenacting this piece of artwork. Let's move on to some cases. So imagine you have a 55-year-old man who can normally walk about 200 yards slowly on the flat, which puts him in NYHA class 3. And he's presenting to you with vomiting and diarrhea rather than with heart failure, because his heart failure has been stable, and he's just a couple of days ago developed severe vomiting and diarrhea. Now, he's had an ischemic cardiomyopathy for the last 8 years. Although I say had been stable recently, he's not stable generally. He's had 2 admissions with heart failure in the last 12 months, which is an ominous sign. He's got fantastic treatments already in. He's had a biventricular ICD for the last 5 years. He's on a regular modest dose of furosemide 40 twice a day. He's on top dose of this sacubitril valsartan drug, 97/103 milligrams twice a day. He's also on a Pleronone 50, carvedilol, typo in the spelling of carvedilol. So 25 milligrams twice daily, and ivabradine 5 milligrams twice daily. So What do you think when you discover him to be apyrexial and bradycardic with a pulse rate of 52 and blood pressure of 90/50 with normal heart sounds and a clear chest and with some renal impairment? So what do you think? What's the issues here? So we have a gentleman who is emptying uncontrollably from both ends, and he's got a poorly heart. So what are you going to do about this for him? So what do you think's wrong with him? So I'm sure, yes, dehydration. So he's got a high urea relative to his creatinine. Your urea, it's different for everyone. It depends upon your protein catabolism. If you're a bodybuilder, you'll have a relatively high urea to creatinine. If you're an asthenic elderly patient, you'll have a relatively low urea to creatinine, and it tends to be lower for women versus compared to men because of lower muscle mass. But as a rule of thumb, your urea tends to be about 10% of your creatinine. So here, the fact that it's high suggests either that you're dehydrated or maybe you've had a GI bleed, which would also be possible here, but not likely unless he's got a Mallory-Weiss tear, for example, from vomiting a lot. So high ureatic creatinine suggests that he is dehydrated, and he's quite bradycardic with it. Why is he not tachycardic if he's quite significantly dehydrated and hypotensive? Very good. You must have been typing that before I started asking the question. So he's on a big dose of carvedilol, and this could damp down the natural adrenaline rush that you would get. Uh, you're suggesting heart block, Dr. Al. Well, he's got the biventricular defibrillator in. That often will cause you to, if he's at rest, it may drop his rate to 50 because then you preserve battery life. It'll obviously speed up as he becomes more active. So this pulse rate is because he's on the carvedilol. And the blood pressure, we don't know what his normal blood pressure is. It could be that it's normally 90/50. If it's normally 90/50, should we be trying to drop some of these medications to bring his blood pressure up? Can't have a patient walking around with blood pressure of 90/50, can we? So the answer to that is that we all we're suggesting remove a pleuronone in view of potassium. There is some eagerness here to take away these life-saving drugs, isn't there? I, I'm forever having to say, please, please don't stop and reduce life-saving drugs in this gentleman who's had 2 admissions in the last 12 months. This guy is hanging on by a thread, and if you take away the things that are keeping him going, you can expect him to do badly. So in a normal situation, blood pressure of 90/50 would be absolutely fine. In this situation, the question is it new or old? And in normal times, the other thing would be to ask about symptoms. So is he lightheaded, or does he go dizzy when he stands up? Is he falling over? If so, then we'll have to reduce the heart failure medications. But in this emergency setting with somebody who's very dehydrated, we can ask those symptoms, but we want to know what the baseline is to know if this gentleman is acutely unwell with the dehydration or if he's just dehydrated. We also want to know what his baseline renal function is, because if the creatinine was 90 yesterday or day before and is rapidly declining, that's another big concern for us, isn't it? So we're going to rehydrate him rapidly, don't we? Um, and we could do A, B, or C here, but I think you don't know the answer until you know what he's normally like in himself. If he is lightheaded and you think that he's not mounting a tachycardia that he ought to be because of his carvedilol, then rehydration would be appropriate with IVs, otherwise oral would be fine. I don't normally like giving heart failure patients IV salt because we're trying to get rid of salt most of the time with them. But when you've lost a lot of salt with your diarrhea and vomiting, that would be entirely appropriate. But either of these would probably be reasonable. What about the heart failure drugs? So he's, imagine that his blood pressure is normally about 90/50 and his heart rate's normally in the 50s. Do we want to do anything with the medications? So we've got this acute renal failure and dehydration. Do you want to stop those? So options, please, A, B, or C. Do you want to hold all of the drugs for a week and let the GP review? Or do you want to just hold the diuretics for 48 hours and then restart? Or do you want to hold the diuretics and the sacubitril valsartan until the nausea settles and then restart? So we've had option C, C. Any other options people want to go for? So it does depend on the baseline. Yes, thank you, Ben. So if the baseline EGFR was creatinine was 50, and we're seeing a big jump here. If his blood pressure was lower than usual, if he was symptomatic with lightheadedness, if he's really not keeping anything down at all versus he's keeping a bit down, then we could probably simply hold the diuretics and encourage oral rehydration and go for option B. If his EGFR is substantially off baseline, then that does give us more concern. But remember, it's not the sacubitril valsartan that's causing the problem here. It's not the valsartan bit of it. It's the fact that he's dehydrated. So maybe we need more blood pressure for the patient, and that would be the reason to stop it rather than because of the renal failure per se. So it's based around what blood pressure you think he needs to perfuse his kidneys well and get him through this time of dehydration. Good. Any questions about that? So feel free to type questions in while I move on to case 4. So imagine exactly the same patient, but this time round, we're just going to change the patient's gender in the interests of equality. So identical patient in every other detail. So imagine that this lady, identical baseline information. She's presenting differently. She hasn't got the nausea and vomiting. So she's called you up and you're working in general practice. And she phones to say that she's gained 2 kilos in weight over the last 48 hours. So what are you going to do about that? Are you going to say, this isn't an emergency? She can have a routine appointment if she really wants one, but should think about taking advice elsewhere. Are you going to urgently check her renal function and increase her diuretics? Are you going to just keep an eye on this because we don't want to overreact? This is a complicated patient. She's obviously had to work quite hard for a long time to be stable, and we just let's not overreact and rush. Or do we want to get her in hospital and get somebody intelligent in hospital to sort her out? So we've got lots of option Ds coming through. We did have one option B, so that's wanting to do something immediately themselves. So now we want to start some IV furosemide. So obviously option A is ridiculous. Option C, that's the big one here that I want to make sure that you don't go for, because patients with heart failure can gain weight at about 1 kilo a day, And if you review her in a week's time and she's gained a stone of fluid, then it's not going to be something that you can manage in the community anymore. We run an urgent heart failure clinic, and these patients can be sent to us. We'll see them within a few days of referral. We triage them, and we can see them, within a day if we think that they critically need to be seen urgently, and this person would be in that category unless immediate treatment is being given. But this patient can be managed as an outpatient, providing their renal function is holding. She's only gained 2 kilos, so we've got to her fast enough. And a lot of these patients are really very good at spotting that things have changed and they need medications increasing. Others are not so good. It never ceases to amaze me that I can diurese 20 kilos of fluid out of somebody and they can come back 20 kilos heavier a month later, and they've not sought help in the interim. But many of them are very good at letting you know that they've got the acute gain in fluid. And if you rapidly increase the furosemide, if you increased furosemide, you can prevent the need for an emergency admission. And an appropriate increase of the furosemide, what would you say we should increase it to? So bearing in mind that her renal function is stable and you've confirmed that you think this is heart failure rather than another cause. So I've had 120 suggested, so 80/40. Is everybody happy that 80/40 is good enough? So I would put her on to 80 milligrams twice a day, because you need to have a substantial reaction here. If she had gained 2 kilos over the course of a week, then probably 80/40 would be reasonable, but this is over 48 hours. So she needs 80 BD and a recheck in a week to see that she's making progress, and she needs to be signposted to phone us up if she isn't improving in the interim. And by weighing herself daily, that can be the most useful way of assessing, is she responding to the diuretics. We want her to lose maybe 1/4 to 1/2 kilo a day. In the community, we don't want to go as fast as we would in hospital, obviously. We should also ask, is she getting polyuric with the increase in furosemide? Because that patients will tell you about straight away. If they're not peeing anymore, any increase with the diuretics, then we will need to escalate. Questions coming through. Would she need an echocardiogram? So this sort of a patient has got a long-standing ischemic cardiomyopathy. We know it's a severe LV impairment because otherwise she wouldn't have the biventricular ICD. How much would an echo add to treatment? Well, maybe she's developed pericardial effusion. Maybe she's developed severe mitral regurgitation or aortic stenosis. So an echocardiogram would potentially add to the treatment, depending upon how long ago the last echo was, and is she physically a candidate for further treatment. And she would certainly be likely to be a candidate for further treatment based on the story I've given you. So yes, I think an echocardiogram is indicated here unless she's had one recently. And you should certainly listen out for any new murmurs, and she certainly needs her renal function checking. Great. So now case 5. So very different sort of patient this time. We've got an 82-year-old lady, and she lives in a residential home and has developed severe peripheral edema. She's got quite a lot of past medical history, as befits her being in a residential home and being elderly. She's had a stroke 10 years ago. She's diabetic type 2, hypertensive, got a smoking history and COPD. She's not smoking anymore, and she's got some renal impairment as a baseline. She's on quite a bit of furosemide, 80 twice a day. She's also on aspirin and simvastatin, metformin, amlodipine, 10 milligrams once a day, and some inhalers. Now she's apyrexial and heart rate of 90, blood pressure's 120/80, normal heart sounds. So she's all right clinically. She's reasonably stable. But there's this severe peripheral edema that you've been asked to see her for, and she's fairly vague about this as a symptom. She's not really that sure how long it's been there for and how different from usual it is, but she has got very boggy legs. So imagine this complex elderly lady who's got this bad condition called diabetes, and her chest isn't very good, and her brain is seen better days, and she's now got this boggy pitting edema in her legs. So what are your thoughts about this? So right heart failure has been suggested. Um, so the presence of fluid buildup in the legs uh, is a sign of right heart failure, but I would tend to call it congestive cardiac failure rather than right heart failure. And that's because it's unlikely that the primary problem here is failure of the right side of a heart. The issue is going to be problems on the left side causing higher pressure in the lungs to get the blood out and into the left atrium, and then that means that the right ventricle has to work harder to get blood through the lungs, and the right ventricle starts to fail, and then you get the peripheral edema because of that. So yes, I agree with that this is a right heart failure type symptom, but it's not very helpful to think about that, because unless you specifically mean this lady's developed primary pulmonary hypertension, or more properly called precapillary pulmonary hypertension, or thromboembolic heart disease, or very good, Joseph, cor pulmonale, any of those things. And yes, you can call it right heart failure, but otherwise it's better to think of it as congestive cardiac failure. So I've given you a background of COPD, and it's possible that she's developed cor pulmonale secondary to that, but that's a pretty rare condition. Uh, Severe cor pulmonale that presents like this is possible here, but is rare. So unless severe COPD is the main part of her diagnosis, I wouldn't be rushing towards that. Um, so what are you going to do for this lady, given these blood results? We don't know exactly what's going on yet, do we? But we got a sodium of 121, so she's pretty hyponatremic, isn't she? Um, so hyponatremia might be chronic and dilutional. So she might have chronic hyponatremia. It might be that she's fluid overloaded, and that's causing the hyponatremia. We don't for sure know yet, do we? She's got a level of renal impairment, and her urea is 12.6. What do we think of the urea relative to the creatinine here? Is that normal? Is it low? Is it about what we might expect? So I would suggest to you that for an elderly lady, that's probably an appropriate ratio. Um, so So, Ben, less than 10% would suggest overhydration rather than dehydration. If it was 14 plus, you might be thinking dehydration. We don't know what her baseline is. Maybe her normal creatinine to urea would be more like 5%, because she's quite an asthenic elderly lady. So we don't know. Normally, maybe she runs with a urea of 20 in order to keep her sufficiently dry that she doesn't fill up with fluid. So we don't know for sure, but this would probably be about right for her in terms of that ratio. And we know she's CKD stage 3, so whether this is much different from baseline, we're not so sure. So this lady's presenting to you with this peripheral edema. We've suggested that it's heart failure, which is the diagnosis which you're clearly going for in this urgent heart failure emergencies talk. Is there anything in her medication list that gives you a pause before we move on and start treating her? Amlodipine. At 10 milligrams once a day, we can expect that to cause peripheral edema. It's not typically quite so pitting as this lady's I've demonstrated to be, but it could be certainly due to amlodipine here. So we definitely need to think about doing something about the amlodipine as a potential cause of this. We could do things like check an NT-proBNP to help us to the diagnosis. Here, it isn't an emergency because it appears to have been developing for some time. And when I say it isn't an emergency, um, I don't mean you can sit on this for the next month or two. What I mean is you've got time to do some blood tests and make your decision about treatment tomorrow. Dr. Al has suggested, supposing she's been on amlodipine for years, would it cause edema now? Absolutely. Patients can take it and be stable for years and then develop it as a side effect. As leg edema is very, very common as a side effect of amlodipine. I wouldn't necessarily stop it if it's working well for the blood pressure and the patient's not bothered about having slightly puffy ankles. But in some people, it can cause severe edema, and then I certainly would be wanting to stop it. Why does it cause problems after years on it when it hasn't to date? Probably it's related to there be multifactorial reasons behind it, and as you're getting older, everything is working slightly less well, including the lymph system. So what are we going to do for this lady given that presenting scenario? Do you want to admit her to hospital given she's got severe fluid overload and give her 240 milligrams IV over 24 hours? Or do you want to, because you're concerned about the hyponatremia, and we mustn't give frusemide. Everybody knows how frusemide works, don't they? So frusemide increases the amount of sodium that you're pushing out into your loop of Henle, and with it goes fluid. So frusemide makes you wee out salt and water. So we don't want that, do we? We use some GTN, carefully titrated to that blood pressure, and then we can stop her frusemide and the spironolactone. Or do you want to just continue with the oral frusemide, because we obviously don't want her heart failure to get worse, but we want to restrict her fluid intake and give her oral sodium, so basically treat her for SIADH? Or is the clever way out of this to phone up the renal specialists and arrange ultrafiltration for her, and that way we can sort out her electrolyte disturbance and not have any of these problems? So I've had one answer of A. Does anybody want to plump for a different option here? Okay, so if we're going to admit her to hospital, then 240 milligrams IV over 24 hours is probably the right dose of frusemide to give. It might also be possible to manage her at home, and these patients can be treated. The concern I would have is the low sodium, because it really is quite low now and might start to cause problems in and of itself, particularly if we're causing relatively rapid fluid shifts. But on the other hand, how is she going to do in hospital? Is it going to lead her to become confused? Is she going to not eat properly? And is she just going to do very badly with a change of setting? So consider the patient carefully, but the if we were managing her at home, I'd probably switch her to bumetanide 3 milligrams twice a day and add in bendraflumethiazide 2.5 milligrams once a day. IVGTN will not diurese. It will reduce the preload and afterload, and it can treat pulmonary edema, but it won't do anything for fluid overload, so it's definitely wrong. It would be completely unhelpful. And fluid restricting hasn't really been shown to help in heart failure. It probably won't be very helpful here. And giving oral sodium's absolutely the wrong thing to do because she'll be overloaded with sodium. It's the fluid overload that's diluting the overload of sodium. So giving her more sodium isn't going to help the heart failure situation. So definitely don't want to give oral sodium here. And we could do ultrafiltration, but there's really no need. If she's fluid overloaded with heart failure, the sodium will come up quite nicely by giving the furosemide. So we admit her and we put her on IV furosemide 240, and we've talked about how important it is to not end up pinned to a wall by a bull and to properly treat patients' heart failure. So are you going to diligently start ramipril and bisoprolol, or would you just start ramipril or just bisoprolol to start off with, see how she goes, and then add the other in? Or do you want to just sit on your hands, clear this fluid overload, and then worry about the medications? What does everybody think? So we've had a option A gone for. So in fact, two people have gone for A simultaneously. So we don't know why she's got heart failure yet. We haven't done an echocardiogram. And if she's got heart failure with a preserved ejection fraction, there's no reason to give her ramipril or bisoprolol. So we should certainly find out what the echocardiogram shows first. If she's got LV systolic impairment, then it can make sense to get the drugs started. And that then means you've optimized people before they go home. It's a hassle optimizing drugs. It may not happen that effectively. So the more you can do in hospital, the better. But somebody like this, whose blood pressure is a bit borderline, whose renal function is a bit borderline, you could tip things by starting drugs too soon. So option D here would probably be reasonable. Option B of just starting ramipril, that's probably also reasonable. I wouldn't start bisoprolol at 2.5 in somebody with significant heart failure. You should start at 1.25 and gradually up titrate. Starting it too soon can cause patients to decompensate. So I would tend to avoid the bisoprolol until later in the admission when she's more stable. Maybe look to start it before discharge. So option B or D would probably be the best two here, but really option E is we need an echocardiogram because otherwise we don't need to start these medications. So 72 hours pass and then your junior calls you and says that she's doing really well. She's passing lots and lots of urine and her weight's going down. But I'm worried about her now because she's dropped her blood pressure. She's hypotensive, and I've got these blood test results hot off the press, and the eGFR's now dropped from 45 to 20. So what do we do now? Do we think that it's this poisonous ACE inhibitor that has caused her renal failure? Why on earth do we start that in an 80-year-old just because the echo came back showing LV systolic impairment? So we'll stop that, we'll carry on diuresing her and all will be fine. Or is it that we've given her these terrible diuretics and they have damaged her kidneys, because it says in the BNF that furosemide is nephrotoxic. So we stop those as well as stopping her ACE inhibitor. Or the other way around, just stop the diuretics, carry on the ACE inhibitor? Or do we want to transfer to cardiology for IV dopamine to support diuresing her and then keep on going? So I've had an option D from Joseph. So Dr. Al is asking how low is her blood pressure? Well, The question is, how low is it relative to normal for her? So we said it was 120 on admission, but if it's normally 160, maybe it's still too low at about 120. Imagine her blood pressure is about 100 systolic. So Ben is wanting to do D. Does anybody else want a different option? So the thing here is you don't have enough information. Passing good amounts of urine, what does that mean? Does that mean she's passing negative fluid balance of 1 litre a day, which is about what we're aiming for? Or does good amounts of urine mean she's peeing 3 litres a day? Fantastic. Let's keep on going and really dry her out like a prune. We might be overcooking the diuresis, in which case reducing the diuretic would be the right thing to do. Weight decreasing, we want it to go down by about 1 kilo a day. So weight decreasing could mean it's going down by 0.1 of a kilo a day, or it could mean that it's going down by 4 kilos a day. So we need to know what these top two statements mean, because if she's being over dried out, over diuresed, then we need to slow down. The hypotensive bit, that could be that we've started an ACE inhibitor and we've dropped her blood pressure, or it could be that her she's dehydrated and therefore hypotensive. So we don't know the answer to this until we've assessed the top two properly. Similarly, the eGFR is dropping. We expect eGFR to decrease in patients who we're diuresing because we have the same amount of creatinine, but we have a smaller amount of water in the body, and the creatinine's distributed through all that water. So if we've got less water and the same amount of creatinine, that means that the creatinine concentration will increase. So if the creatinine's going up by about 5 to 10 a day, that's expected, that's fine. But if it's dropping rapidly, and the eGFR here I'm giving you rather than a creatinine, that's dropping fast. So this definitely needs something doing about it. It's not an expected happening. And that could be that the ACE inhibitor is nephrotoxic. Furosemide, I've never seen it be nephrotoxic. There are papers out there that suggest that it is, but what is bad for you is taking too much furosemide and being too dehydrated, or taking not enough furosemide and being fluid overloaded, and the heart's overloaded, cardiac output goes down because of its overload. Kidneys are very sensitive to that. So the right amount of furosemide is the critical thing. So we don't know the answers to this from the information I've given you, but I wouldn't be wanting to rush to go for IV dopamine. I would want to stop the ACE inhibitor. I would want to stop certainly the amlodipine. There's no reason for her to carry on with the amlodipine here because her blood pressure is good and we want more blood pressure to allow us to diurese her. So I would have stopped that at the beginning. But I certainly, if we had started ramipril, having found her to have LV systolic impairment, now would be the time to stop that drug because of the hypotension. She might not need dopamine if she is not too unwell and can manage by holding meds. So yes, we don't want to rush for the dopamine if we can help it. The evidence base for dopamine is very weak, but I do find that it's very helpful in patients with low blood pressure and borderline renal function who are not responding to diuretics. So ACE inhibitors are always being, or constantly being, accused of being bad for kidneys. And this, it's an ugly slide. I'm sorry, but I've given you all the information you need to answer this. So if we look at the SOLVED study, one of the early trials of enalapril, one of the early ACE inhibitors, which is still a good drug and can be used, although we don't tend to prescribe so much locally, which is no good reason for that. So that in that trial, which had patients with creatinines up to 221, there was this very marginal, look at this tiny impact on eGFR. So tiny impact, meets significance, but it did not in the trial have a substantial impact on eGFR. If we look at a 20% decrease in EGFR from baseline at 14 days, which is kind of what we're looking for, because we start an ACE inhibitor, we want to recheck renal function in 1 to 2 weeks. We can see that that does happen more often with enalapril compared to placebo. But when I say it happens more often, the p-value doesn't quite reach significance for it. So we do perhaps see a little bit more of this, but not really measurably so, even with 6,300 patients. So you shouldn't really expect to see a decrease in EGFR. Meanwhile, in the trial, 10% of patients have a decrease in EGFR of over 20%. And this is a factor that these are poorly patients and you're giving them something that drops their blood pressure. And it's likely to be that, or actually, no, I tell a lie, you're giving them, just poorly patients a sugar pill or a blood pressure medication, an enalapril. But either way, there's a significant risk because they're poorly patients that they experience a decrease in their EGFR. It's not necessarily the active drug which is causing the problem. It could just be happening anyway. And overall, these patients do better over the course of a year because ACE inhibitors are good for renal impairment. The renal team are regularly prescribing ACE inhibitors in renal impairment. So the bottom line of all this is that ACE inhibitors relatively infrequently cause renal failure, and these patients are at risk of developing renal failure simply because they're poorly patients. So if they do have deterioration in renal function by over 20% decrease in EGFR, then you should consider stopping the ACE inhibitor. Look for the other possible causes of acute renal failure because they are common in this group, and then consider retrialing it because these are really good drugs. They'll reduce mortality by 30%. So if you're denying the ACE inhibitor to these patients, have a good reason for it. And if you're diuresing in hospital, that's not a good reason to say ACE inhibitors are to be avoided. Just get them stable and then think about starting the ACE after discharge. Get the heart failure team to do it. If they are truly intolerant of an ACE, we could think about isosorbide mononitrate and hydralazine in combination, which have got some benefit in this cohort. But these medications are not well tolerated. They're not easy to titrate because there's so many stages to it. Spironolactone is another really good drug when you have left ventricular systolic impairment. So how do you go about prescribing that? If your patient's EGFR is over 50, you can either start it at 12.5 once a day or possibly 25 milligrams once a day, and then double it up to 25 milligrams once a day. You can even give 50 milligrams once a day or 25 twice daily, but I would do that in stages. And you're checking the renal function after 1 week. And if they're on an ACE inhibitor or an ARB, then you also want to do it again at 4 weeks and then every 3 months. So they do need a lot of monitoring. And this is not optional because often their potassiums do go up. And you have to monitor this. You can't just tell the GP to do it because they're not going to have time to react to it. So starting an ACE inhibitor or starting spironolactone or an MRA in patients who are already on an ACE or an ARB is a little bit complicated. And while it's very beneficial, about 20% reduction in mortality, it does need thought and monitoring. If they've got renal impairment, you can start it with EGFR down to 30, although you might start to get a bit concerned about risk of complications and base it on your patient. But then we'd probably start either 12.5 once a day or even alternate days at the lower end of the range, and then think about doubling to 12.5 a day. You probably aren't going to get up to 25 unless their EGFR is to the top end of this range. If the potassium goes above 5.5, we'd halve the dose of the spironolactone. If it's above 6, then, or if the renal function is deteriorating, then we would have to stop it. So we're quite happy with potassiums up to 5.5. If it's going up and we really want to get the patient started on spironolactone, we can now use potassium binders. So that's something the heart failure team can do where patients do truly have elevated potassiums with these drugs, which is relatively uncommon, but certainly happens. So we would want to know about it if you can't get ACEs or MRAs on patients because of their potassium levels. So that's how you use spironolactone, but this is in patients with a reduced ejection fraction. There is some evidence base for spironolactone with heart failure with a preserved ejection fraction. So if you've got a HFpEF, we might also use spironolactone. And in the trial called TopCat, it was added to patients already on ACE inhibitors in about 90% of cases. So we add it again to the ACE or ARB. TopCat, it was borderline. It only met significance if we excluded the patients from Eastern Europe who were in the trial, which is a bit dodgy to do post hoc analysis. So the evidence base for this is very good in reduced ejection fraction, not so good in preserved ejection fraction, but it can be helpful with symptoms. Wonderful. That's as much as I wanted to say about heart failure. Any questions? Very happy to take.